Welcome back to this next video in which we are discussing coronary artery disease. Okay, so we've now talked about stable angina pectoris, which is this chronic condition which is going to result because of coronary artery disease. So if you've got an atherosclerotic plaque in one of your coronary arteries, an example that we've been using throughout the video is the left anterior descending artery, then that is going to be continuously limiting blood flow to the area that artery supplies, and the result of this is that the artery ends up dilating to its maximum amount around that area where you have the atherosclerotic plaque to try and maximise the amount of blood that you're getting through there. And the problem with that only arises when you actually try and exercise. So at rest it's perfectly fine because the dilation of the artery compensates for the atherosclerotic plaque reducing the diameter of the lumen. However, the problem then comes when you exercise, when you exert yourself, because normally when you exert yourself and the heart then requires more oxygen to be delivered to it, the way that you achieve this is by dilating the coronary arteries. But this portion of the coronary artery around the atherosclerotic plaque is completely maximally dilated already, so we can't dilate it any further, so we're not going to get an increase in blood flow through that coronary artery when you actually are exerting yourself, and that then leads to the crushing chest pain when you exert yourself, which is going to occur chronically every time you exert yourself once you've got coronary artery disease. So stable angina pectoris is the chronic condition that you get due to coronary artery disease. What we're now going to move on to is what can happen very acutely, an acute condition that can arise because of coronary artery disease, and this is what's known as acute coronary syndrome, or ACS for short. Okay, so acute coronary syndrome. So there are loads of different scales of acute coronary syndromes. There are unstable angina, and then there is heart attack, but then there are also two different types of heart attack. There is what's known as the Subendocardial infarct and the Transmural infarct. And what I want to do is firstly describe what's common to all of them, because the actual thing that causes them is common to all of them. Generally it's caused by rupture of an atherosclerotic plaque, which is clearly an acute event. And then the different types of acute coronary syndrome, they just represent the different severities of the blockade of the coronary artery that follows the thrombus formation on top of the ruptured atherosclerotic plaque. But let me first explain what's common to all of them, which is the rupture of the atherosclerotic plaque and the formation of a thrombus on top of the ruptured surface of the atherosclerotic plaque. Okay, so we're now going to talk about acute coronary syndromes, which are acute coronary events that are going to occur, which you are at risk of having if you have coronary artery disease. Okay, so acute coronary syndromes then. So what's going to happen, as I've been saying throughout the video, is we're going to get the atherosclerotic plaque in our coronary artery is going to rupture, and on the ruptured surface of the atherosclerotic plaque you're going to get a blood clot forming, and when a blood clot forms in the middle of a perfectly intact blood vessel we call that a thrombus, and the process is known as thrombosis. So let me just draw a little flow diagram for this. So let's say we have our atherosclerotic plaque here, okay, and I'll draw this in green here, like so. So this is the basement membrane, if you like, and we'll have the endothelial cells. So actually I'll make it a better picture. We'll actually draw out the atherosclerotic plaque with its different layers here. So here are the endothelial cells sitting on the basement membrane, like so. And then of course we know that the two main portions of the atherosclerotic plaque are the fibrous cap here, like so, in orange, and then we'll have the lipid core underneath, which I'll just draw in yellow here. Now, atherosclerotic plaques can rupture, and when they rupture what's going to happen is some part of the top here is going to get blown off. Okay, it's going to sever off, and then you're going to have the exposed under portion of the atherosclerotic plaque now exposed to the blood, and that's what's going to drive the coagulation process. Okay, now atherosclerotic plaques are at different risk of rupturing depending on how thick the fibrous cap is. If the fibrous cap is very, very thick, then that atherosclerotic plaque is at much less risk of rupturing. And we call atherosclerotic plaques which have a very thick fibrous cap stable plaques or stable atherosclerotic plaques. Whereas, if you've got a very thin fibrous cap, remember the fibrous cap is this tough bit, that's the stable bit of the atherosclerotic plaque. Okay, so it makes sense that if you've got a very thin fibrous cap, you're going to be much more prone to rupturing, and indeed you are, and such plaques which have a very thin fibrous cap are known as unstable atherosclerotic plaques. But of course, all atherosclerotic plaques can potentially rupture, and the actual trigger of the atherosclerotic plaque rupturing isn't particularly well understood. So the final thing that causes the atherosclerotic plaque to rupture, that isn't very well understood at all. But what we do know is that in the acute coronary syndrome, what's going to happen is one of the atherosclerotic plaques in your coronary blood vessels is going to now rupture. Okay, so I'll draw this here. So rather than having it with its complete surface now, we're going to have it ruptured now, like so, and the layer of endothelial cells is certainly going to have gone now. So here is our atherosclerotic plaque now. So here's the fibrous cap, like so, and here is the lipid core, and you can see that the inner portions of the atherosclerotic plaque, the fibrous cap and the lipid core here, are now going to be exposed to the blood. Okay, so now here is the basement membrane torn off this top bit, and here are the endothelial cells. Okay, and this is going to drive the process of coagulation to occur on top of this ruptured surface. So I'll re-give my speech about coagulation. So I'll write down some of the key words this time. So coagulation is the process whereby the blood goes from being a liquid to being a solid. Okay, and this occurs because of platelets and coagulation factors within the blood. And I just want to give a brief summary of the coagulation process. So normally coagulation occurs when you have a hole in the side of one of your blood vessels. So if you have a hole in the side of one of your blood vessels, you want coagulation to occur, and you want it to form a blood clot, known as a hemostatic plug more properly, in the side of that hole in the blood vessel to prevent blood leaking out of the hole. However, this can now occur on top of this ruptured surface of the atherosclerotic plaque, and the reason is that coagulation is triggered by the platelets and the coagulation factors seeing molecules that they would never normally be able to see, such as collagen. Collagen is one of the key examples. So normally they would never ever be allowed to see collagen. It's covered up by the endothelial cells. So the endothelial cells make sure that the platelets and the coagulation factors never see collagen. Whereas now, when you've got a hole in the side of the blood vessel, or when you've got this ruptured surface of the atherosclerotic plaque, suddenly they are going to see collagen, and that's going to be the trigger for the coagulation process to begin. So, there are two major parts to the coagulation process. Firstly, there's the formation of a platelet mass. Okay, platelets can aggregate together and form a great big mass. And then there's also the formation of the fibrin meshwork, which, like a spider's web, entwines the platelets and holds them together. And both processes need to occur in order to get a proper blood clot forming. Just having the platelets aggregating together isn't enough. They don't adhere together very strongly, and they do need a fibrin mesh to hold them all together. So we'll talk about these two different processes in a tiny little bit of detail then. So what's going to happen is the first step then in the formation of a platelet aggregate is that platelets are going to adhere. So there's the three A's in the coagulation process. So you're going to start with adhesion. So I'm going to draw my platelets now on as little dots here. So platelets are going to adhere to all of the different molecules that they've now come into contact with on this ruptured surface of the atherosclerotic plaque. Okay, so they wouldn't normally adhere to endothelial cells. They're only adhering here because they're seeing molecules that they would never normally be able to see, and the receptors on the surface of those platelets are directed against these molecules. So here we're getting platelet adhesion over the surface of the ruptured atherosclerotic plaque. Then what we're going to get is something known as platelet activation. Okay, now let me explain what is meant by platelet activation. So platelet activation is a complex concept. It refers to a huge change in the behavior of the platelets. Okay, and I will go through the different behavioural changes at different points, so in my little explanation of coagulation here. So, the platelets that have adhered to the surface, to the ruptured surface of the atherosclerotic plaque here, they have had receptors bind to all sorts of the different molecules, for instance collagen, that they are now exposed to, which they would have never previously been exposed to in the intact blood vessel. They are going to undergo this activation process. They're going to undergo major changes in their behaviour, which will be triggered by these receptors activating intracellular signalling pathways. One of the major things that changes when platelets activate is they gain the ability to bind to other platelets. Okay? Now, these platelets then are going to be able to bind to other platelets, but they can only bind to other platelets that have also been activated. Now this presents a problem because all of the other platelets in the blood vessel here, they have not yet been activated, so that means that only the ones that are already on the surface here are actually going to be able to adhere to each other. But we want other platelets, well, we don't want, because this is obviously occurring in the middle of a blood vessel, but if you think about this occurring in the hole in the side of a blood vessel, you want other platelets to now adhere on top of these other platelets that have adhered on the broken surface. So if you think about having a hole in the side of the blood vessel, and I'll just draw this because it's important to understand why this all makes sense in the context of physiology here. So if we've got a blood vessel here, and we've got a hole in the side of the blood vessel, then platelets would have adhered all around the edge of that hole. Okay, but you want to actually form a plug in the hole, so you need all of the platelets in the middle, if you like, that aren't adhered to the outside to start adhering to the platelets that are already adhered to the outside. So you've already used up all the space for platelets to adhere on the surface. You now need platelets to adhere on top of these ones, okay, as part of the hemostasis process. So this is what's going to happen here. So what has to happen is these activated platelets here that have adhered on the surface, they send out molecules to activate other platelets so that they too can stick to these activated platelets. So activation involves not just this change in properties so that you can adhere to other activated platelets, that you can bind to other activated platelets, stick to other activated platelets, but it also involves releasing loads of molecules, important examples of which are ADP, thromboxane A2, TXA2. I mentioned those two because we will actually see drugs later which can prevent these two from working. Okay, so activated platelets release these molecules, adenosine diphosphate thromboxane A2, and I suppose I should probably just write out the full name of TXA2. So this stands for thromboxane A2. Okay, so they release these two molecules, and these molecules are going to go off and they're going to meet other platelets in the lumen of the blood vessel here, and they're going to result in those platelets becoming activated as well. So you're going to get this chain reaction of activation of platelets, so that it isn't just the platelets on the surface here which have actually seen these interesting molecules which are going to become activated. All of the other platelets in the blood vessel are going to become activated as well. And these are now going to start aggregating together, so that's the third step now. Okay, the activated platelets, they all have the ability to bind to one another, so you're going to get aggregation. Okay, so you're going to now get platelets binding on top of these ones because these have activated due to the chain reaction here, and they're now all capable of aggregating together. Okay, so you get platelets forming this aggregate on top of the ruptured atherosclerotic plaque, like so. Okay, and in the physiological context, where you've got a hole in the side of your blood vessel, you'd get platelets initially adhering on the exposed surface of the blood vessel, so the broken surface of the blood vessel here. Then you'd get the activation of those platelets that have initially adhered there. They then release these molecules to cause this chain reaction to activate all the platelets that haven't yet seen interesting molecules. Those platelets will respond to these molecules, activate themselves, of course release even more chain reaction molecules, which is why it's a chain reaction, and then they'll all be able to aggregate together, so you'll be able to get platelets sticking on top of the platelets that have bound to the broken surface of the blood vessel, and therefore you'll start to form this aggregate of platelets that can actually plug that hole. Okay, so this is the formation of a platelet plug, if you like. Now, of course, here it's occurring in the middle of a blood vessel. Okay, now that's one of the processes that occurs for coagulation. That's the production of a platelet aggregate. The other process that occurs in coagulation is the activation of the coagulation factors. And overall, the coagulation cascades are incredibly complicated. There's two of them for a start, which is incredibly complicated, intrinsic and extrinsic coagulation cascade. But the overall result of coagulation cascades are to convert clotting factor number 1, which has another name, a fancier name, it's known as fibrinogen, into clotting factor 1A, which is called fibrin. So this is, the old name for this is coagulation factor 1 or clotting factor 1, and fibrin is the active form of clotting factor 1. Okay, so let me just draw a little picture for this. So all of the coagulation factors, they are produced by the liver and they're secreted into the blood in an inactive form. Okay, so most of the coagulation factors have an inactive and an active state. There are a few exceptions, such as coagulation factor 3, I believe. Tissue factor doesn't have two different states. But most of the ones that are circulating in the bloodstream are going to have two states. They're going to have an inactive state and an active state. They're secreted by the liver into the bloodstream in the inactive state, and usually they never activate, okay, until the coagulation cascades are initiated, and they're initiated in response to seeing molecules that you would never see normally, such as collagen. Okay, so fibrinogen is secreted by the liver, and it can be converted into fibrin. So if I just draw a little picture of this, so let's have this representing fibrinogen, and it really does look like that, with two sort of lobes separated by a connecting stalk, like so. So here's my picture of fibrinogen, and then it's going to be converted into fibrin, which I'll just show as a rectangle to show that it's changed. It doesn't really get rid of the two lobes, but just to show a difference, I'll have it shown as a rectangle here. Okay. So this is what the coagulation cascades are overall going to lead to. They're going to lead to the conversion of fibrinogen into fibrin, and the coagulation cascades will be activated by seeing molecules that you would never normally see. So overall, the two coagulation cascades are just going to lead to this conversion, fibrinogen being converted into fibrin. What's then going to happen to fibrin is it spontaneously polymerizes. So on its own, with no help at all, these fibrin monomers here polymerize into great big strands, like so. So here, this is a fibrin strand. And then what can happen is the fibrin strands can be interlinked by another activated coagulation factor, specifically coagulation factor 13A, which is also activated in the process of the activation of the coagulation cascades. So you get coagulation factor 13A, the active form of coagulation factor 13, and of course this is just the Roman numeral for 13X for 10 and then 3 I's. This is then going to cross-link the fibrin strands that are forming to form like a meshwork, like so, okay? Which you should imagine as a great big spider's web of proteins in this way, okay? And this is going to be happening alongside the formation of the platelet plug, and indeed actually the surface of the activated platelets, this is really important, the surface of the activated platelets, those can also activate the coagulation cascades. So not only can collagen molecules initially that the coagulation factors are going to be exposed to on the ruptured surface of the plaque or on the broken surface of the blood vessel wall, not only can those activate the clotting factors, the coagulation factors, but also once you've got the formation of these activated platelets here, the surface of the activated platelets, the membranes change. When platelets activate, they change the constituents of their membranes, and now certain constituents in those membranes are now capable of activating the coagulation factors as well, activating the coagulation cascade. So overall you get this fibrin mesh being formed amongst the platelet plug, and you can imagine it sort of permeating in between all of the platelets here and forming a really sort of hard mesh around it. And that's really important because the platelets don't really aggregate together that strongly. They're held together very, very weakly by their own aggregate connections. Really, it's the fibrin meshwork that forms around them that is really important for holding them together. So this is a fibrin meshwork. Okay, so this is the formation of a blood clot then, and when the formation of a blood clot actually occurs in the hole of a blood vessel, then that's good. That's known as hemostasis. When it occurs within an intact blood vessel, a blood vessel that does not have a hole in it, such as a coronary artery where you have got a ruptured atherosclerotic plaque, that is very bad, and that process is known as thrombosis. Okay, so thrombosis does not refer to a blood clot forming in the hole in the side of a blood vessel. It's a pathological blood clot in the middle of a perfectly intact blood vessel, and the actual blood clot itself is known as a thrombus. So many professors do not like the word blood clot or the term blood clot because it doesn't distinguish between the physiological blood clot, which more properly is called a hemostatic plug, which is where coagulation has occurred to make a plug which is actually filling in the broken hole in the side of a blood vessel. So this is a hemostatic plug, and it doesn't distinguish between that and where you've actually got coagulation occurring in a perfectly intact blood vessel, creating an obstruction in that perfectly intact blood vessel, which is a thrombus. So using the words or the terms hemostatic plug and thrombus are better than using the term blood clot. Okay, so back to our overall story then. What's going to happen when you have an acute coronary syndrome is that the atherosclerotic plaque in your coronary artery, and in our example we're talking about it being in the left anterior descending artery, is going to rupture, and on the ruptured surface of the atherosclerotic plaque you are going to get the formation of a thrombus, and the formation of this thrombus is going to hugely restrict blood flow through that blood vessel. I mean, it was already restricted, but remember, in the chronic state the artery had dilated so much that really blood flow wasn't that bad. It only became a problem when you tried to exert yourself, and that resulted in this stable chronic angina pectoris. But now we have got a huge great obstruction to blood flow, and depending on how bad this obstruction to blood flow is will now depend on what actually happens and which acute coronary syndrome you actually get. Okay, so let me now write out then the 3 different acute coronary syndromes. So firstly, there is unstable angina. Now in unstable angina you get this thrombus forming in the middle of your coronary blood vessel, and it does hugely reduce the blood flow through that blood vessel. However, the blood clot or the thrombus isn't bad enough to obstruct blood flow so much that you're actually going to get cells dying. So in unstable angina you don't get heart cells dying. Okay, you do get too little blood flow going down that blood vessel, but it's not bad enough to actually get cells dying. So what do you actually get in unstable angina? Well, you're going to get the same crushing chest pain that you got in stable angina, but rather than just getting it when you exercise, you're going to get it at rest. So you're going to get angina at rest, basically. So angina, it means the crushing chest pain. Okay, and that's completely understandable because now we have produced ischemia at rest. We have this thrombus in the middle of the blood vessel that is hugely obstructing blood flow. And I think I'll just draw this here. So let's say here is our blood vessel, here is the ruptured atherosclerotic plaque, like so. This is the rest of the wall of the blood vessel, and it's a very simple picture here. And let's say we've got this thrombus forming on the top here, but you know, it hasn't completely obstructed the blood vessel. It has hugely reduced blood flow through that blood vessel, but it hasn't blocked it altogether, and it hasn't reduced it so much that you're actually going to get the death of the heart cells at the place where this blood vessel actually supplies. Okay, but what you will get is the crushing chest pain now, just like you would have got it upon exertion. Because now you do have ischemia at the area, it's just that that ischemia is not bad enough yet to kill the actual cardiomyocytes at that area. But it is bad enough to cause the crushing chest pain. Okay, so I hope you understand. You are going to get ischemia bad enough to cause the crushing chest pain at rest. However, you're not going to get bad enough ischemia that you actually get cardiomyocytes dying. So that's the distinguishing thing between unstable angina and myocardial infarction, a heart attack. In a heart attack, the ischemia is going to be so bad that you're actually going to get heart cells dying. So now let's talk about heart attack. So heart attack more properly is known as a myocardial infarction. So heart attack is just the colloquial term for it. So myocardial, of course, means pertaining to the myocardium, the muscle of the heart. And infarction means dying due to lack of blood supply or lack of oxygen. Dying due to ischemia. Okay, so in myocardial infarction, you are going to again get the ruptured atherosclerotic plaque, and you're going to get the thrombus forming on top of the ruptured atherosclerotic plaque, but this time it's going to occlude blood flow so much that it's actually bad enough, the ischemia downstream of the thrombus is actually bad enough to cause heart cells, myocardial cells, to die, hence myocardial infarction. Now there are two different severities of myocardial infarction. You can either get what is known as a subendocardial myocardial infarction, or just as a subendocardial infarct, or you can get the more severe form, which is a transmural infarct. And these are going to result from different severities of blood vessel occlusion. Okay, so a subendocardial infarct is, if you like, the less severe one. So as far as severity goes, it starts with unstable angina, that's the least severe. Then we go up a stage when we go on to subendocardial infarct, a big stage, and then we go up further to a transmural infarct. That's the most severe type of myocardial infarction, or acute coronary syndrome. Right, so in a subendocardial infarct, generally it's very like this picture. So in fact, I won't bother drawing another picture, I'll just use this picture. It's very like the picture for unstable angina. You've had your atherosclerotic plaque rupture, you have got the thrombus forming on top of that, but the thrombus hasn't completely occluded the entire blood vessel. However, if you like, you can extend this a little bit. Okay, so for subendocardial myocardial infarction, it's going to obstruct blood vessel diameter, or the blood vessel lumen, more than it would have obstructed it in the case of the unstable angina, and therefore, even though you're still getting some blood coming through the blood vessel, it's not actually going to be enough to not cause heart cell death. And the reason that this is called a subendocardial infarct is that the portion of the myocardium that's going to die is actually going to be the subendocardial portion. And let me just make sure everyone's happy with the concept of a subendocardial portion of myocardium. So, if I take a cross-section through the wall of, let's say, the left ventricle here, let's say it's the portion of the left ventricle that's supplied by our left anterior descending artery. So here is the left ventricular wall. Now, here is the inside of the chamber here, and of course the inside of the chamber will be lined by endothelial cells, just like the rest of the blood vessel, just like the rest of the circulatory system. Now, the portion of the myocardium, the muscle of the heart wall, that is just underneath the endothelial cells here, is known as the subendocardial myocardium. So it's the inner portion of myocardium. So this is the subendocardial myocardium. So I'll just colour this in green here. So all of this sort of region, this will be the subendocardial myocardium. And the reason it's called that is the endothelial cells that line the chambers of the heart, they are specifically known as endocardial cells, and they're called the endocardium rather than the endothelium. Okay, there is then the concept also of the outer portion of myocardium, which is known as the subepicardial myocardium, because again there is a coating of cells on the outside of the heart known as the epicardium, and this myocardium that's just underneath that is then called the subepicardial myocardium. So these are two fancy words just meaning the inner portion of the myocardial wall and the outer portion of the myocardial wall, and I've made some nice flag there, I don't know which specific one that is. Okay, right, so in a subendocardial infarct, what's going to happen is it's just going to be the inner portion of the myocardium supplied by this blood vessel that has had the thrombus form in it that is going to actually die. Okay, and the reason that it's just going to be that portion is because blood vessels, you'll remember that the coronary blood vessels are on the outside of the heart. So when you have branches of them going in and diving into the myocardium to actually supply blood, they firstly supply the blood to to the subepicardial myocardium, and then they work inwards, and the last bit they supply is the subendocardial myocardium. So if you imagine, what we've now done in the case of a subendocardial infarct is we have occluded the blood vessel hugely, but we haven't completely occluded it. There is still some blood coming through, but there is now not enough blood to prevent ischemia from actually leading to death of cardiomyocytes. Which cardiomyocytes are actually going to die? Well, it's not going to be the subepicardial ones, because they receive the blood first. So they're still going to be receiving enough blood that they're not actually going to die. They're still going to be ischemic, yes, but they're not going to receive so little blood that they're actually going to die due to it. Whereas the subendocardial myocardial cells, they get the last pick of the blood. The blood has gone through all of the subepicardium before it gets to the subendocardium, so they're going to actually get less blood than the subepicardial myocardial sites, and therefore they are actually going to get ischemia so bad that they can actually die due to it, and therefore they're the ones that are actually going to die. So when you get this sort of a thrombus forming where you have occluded blood vessel lumen so much that you actually are going to lead to downstream ischemia that will lead to the death of cardiomyocytes, the portion that's going to die first is going to be the subendocardial myocardium, because the subepicardial myocardium receives the blood first. Okay, so in that type of an acute coronary syndrome, you just get the subendocardial myocardium dying. Then there's the final stage of an acute coronary syndrome, the most severe case, which is where the thrombus that you form on top of your ruptured atherosclerotic plaque is now going to completely occlude the lumen. So let me just draw this on. So here is our ruptured atherosclerotic plaque. Here's the rest of the blood vessel wall, like so, and now the entire lumen will be taken up with this massive great thrombus. Oops. So let me just now draw on the massive great thrombus. So all of this in red, this will be a massive great thrombus here. Okay, it will completely have occluded the blood vessel lumen. So now no blood is actually going to be getting through this coronary artery, which could be your left anterior descending artery. And therefore it doesn't matter whether you're subepicardial myocardium or subendocardial myocardium, you are going to be receiving no blood all the same. It doesn't matter where your position is. So all of them are now going to get ischemia so bad that they are going to die, and therefore you're going to get full wall thickness infarct. Transmural means completely across the wall. So trans means across, mural means wall, so full wall thickness infarct. Okay, so these are the different types then of acute coronary syndromes, and they all depend on the severity of the occlusion of the blood vessel that has actually occurred due to the thrombus formation. So if the severity is very small, okay, or it's as least severe as it can be, so if you've got this thrombus forming in the middle of your blood vessel but it hasn't actually occluded blood flow so much that you're going to get cells becoming ischemic so badly that they will die, then it's called unstable angina. You'll just get the crushing chest pain at rest, but you haven't actually got any dying heart cells. If you're unluckier, then the thrombus is going to be occluding the blood vessel lumen worse, and this will either result in a subendocardial infarct, which is the case where it isn't completely occluding the blood vessel lumen. You're still getting some blood coming through, and that blood is good enough to supply the subepicardial myocardium and stop that from actually dying, but it's not now good enough to actually supply the subendocardial myocardium, which receives the blood after the subepicardial myocardium, and therefore you do get subendocardial myocardial cells dying. Then you'll get a subendocardial infarct. And then finally, the most severe case is that the thrombus completely occludes the lumen of the blood vessel, and in that case you're going to get a full transmural infarct, where the full thickness of the blood vessel wall is actually going to die. Okay, so what I want to do in the next video is talk about the actual cell death process. I'm going to give you a reminder of the different ways in which cells can die, apoptosis and necrosis. I'm going to actually talk about what will happen in the myocardial infarction, and it will be a necrosis process. Specifically, it's a type of necrosis known as coagulative necrosis, so we'll go through what is meant by that, and we'll also explain what the acute complication of having myocardial necrosis is going to be what the acute complication of having a myocardial infarction can be, i.e. how it can lead to sudden death. Then what we'll talk about is if it doesn't lead to sudden death, what will actually happen in the heart following that. And then we'll go on to talking about tests that you can do for looking for myocardial necrosis, and we'll also discuss why it is that a subendocardial myocardial infarct shows up on an ECG differently to a transmural myocardial infarct. So you can actually diagnose the difference between these two different types of MI using the ECG, which is why we distinguish between it so much. This is of course the NSTEMI, the non-ST elevation myocardial infarction, whilst this is the STEMI, the ST elevation myocardial infarction, and I will do my best to explain why having a transmural infarct but not just a subendocardial infarct is actually going to result in ST elevation. But we'll do that in the next video.